Tell us about the keynote address that you made here at AAO 2015.
So I gave a lecture on making discoveries about cataract surgery with big data, and the purpose of the lecture was to first introduce the concept of big data to individuals, because I think not everybody really knows what big data is. So I made a point to introduce that. I also then wanted to talk about cataract surgery. The last Jackson Memorial lecture on cataract surgery was about in the 1950s, and so it'd been a while before we'd really emphasized one of the procedures that's our main procedure that we do in ophthalmology. So that's why I chose cataract surgery. And then it tied nicely with the big data sources that we have in ophthalmology. The Medicare database, I started out doing a lot of research on that, so I presented work looking at endophthalmitis after cataract surgery. I used the Medicare database, and then I went to the IRIS registry, which is the Academy's newest venture into big data that's really going to change the landscape.
So if you were to iterate the top 3 advantages of analyzing this big data from a clinical perspective and a research perspective, what would you say are the points of highest payoff for clinicians?
Well, so for clinicians, the highest payoff is that you're going to actually be able to improve your practice of medicine, which then is going to affect patient care. And so that's the 2 biggest, highest payoffs. And the reason why you can improve your practice is because the way it's set up right now is that you can actually go and compare yourself to what your colleagues are doing on average across the United States. And a lot of us feel, that we're practicing to the top level because we all have been extremely well trained and we're here at the academy or keeping up with other educational courses. But it's nice to know exactly what's happening across the country. And with IRIS, you can then go and see, well, is it a patient mix difference? Am I operating on patients that have more advanced cataracts, for example, or am I operating on earlier cataracts? What would be the expectation for my outcomes? You can kind of look at that, and then you can, once you see that maybe you have a shortfall, maybe you're not where you think you should be compared to the nation, and this is confidential, you could then go and investigate why. And that means you start talking to your colleagues. You start seeing, well, what are they doing? And so you start learning just like you did in your training, where you learn from each other. So it really kind of helps focus that.
Are you also tracking performance with regard to different types of IOLs?
That can be done. That would be something that you would talk more with the Academy staff at the Hoskins Center. But one of the things is that for tracking the IOLs, you have to have a specific number identification. And so then that has to be manually inputted, I believe. Because unfortunately, although the IRIS data is using a software tool to extract data from the electronic medical records, the medical records on a patient might not be the same as the medical records that the surgery center or the hospital has. And so some of the data has to be manually inputted, which then decreases the likelihood of getting it because people are busy, staff are busy, and sometimes these things are done or not done.
So clearly collecting big data is a work in progress. And
right.
How do you see the trajectory of this program rolling out in terms of new features, added features that you'd like to see?
Well, so right now it's really expanding rapidly, as you can tell. They were thinking, I think, that they were just going to have a few thousand individuals involved after the first year. And as we presented yesterday, it's over 10,000. That's a lot. And so I think that right now they're have a lot of data, and it's really making it accessible to people. And so I think that's what they're doing and working on right now. And then I think the other pieces will be phased in. As people have different needs. Right now it's being used for a lot of the requirements in the United States for performance-based. And so, it meets those requirements. They're looking at maintenance of certification through it. And so it's going to provide lots of good avenues for the average clinician. But all of these things are being added on. And so that's a good question for Dr. Park.
Turning now to research applications of this database, what are the most powerful research applications that you see?
Well, so for the research applications, one is the trends of how care is, because at least in the United States, it's regional, and I'm sure it's also global. We all practice a little differently. And, sometimes there are good reasons why there might be regional differences, but sometimes there aren't. And I think this one gives an ability to look at the regional differences. I think it also, once again, gives an opportunity to find patient populations that could potentially be used in clinical trials. That a physician will be able to see how many types of patients they have, or is there enough volume of this type of complication or type of procedure that you could then investigate it with a different type of study, because then you would go more into the randomized clinical trial.
So you intend not only to capture episodic care, but also care longitudinally over time
Yes.
within the same patient group.
Right. As long as they're with that physician or ophthalmologist that's enrolled them. Now, it could be that when patients start moving around with their insurance changing, tracking that too and linking it, that'll be done also. But
Continuity of care is a challenge throughout medicine.
right.
Do you think that the IRIS database will help to link up patients if they move among specialists or move geographically?
I think that would be a great advantage, because you can imagine, as you know as a clinician yourself, sometimes it's nice to know what was happening before, and you don't really know. The issue, though, is the database is confidential, and so it's not like I or you could inquire, well, what happened to patient X before? That way it's not going to help us. But on average, when you look at the average population, you could have an idea. I mean, maybe we'll find that people hopping around in the United States among providers, those that hop around more have worse outcomes than those that stick with one provider for 10 years. And so that you could pick up in a large national registry.
Brave new world of beautiful data.
Yes.
Thank you, Professor. I really appreciate your time.
Thank
I wish
you.
you the very best of luck going forward, and we'll follow your progress.
Thank you.